Hello, my name's Rosemary Dallen. I'm a technologist from Sir Charles Gairdner Hospital in Perth, and I have a case on platelet scintigraphy. Our patient is a 37-year-old female with immune thrombocytopenia, or ITP, which is low platelet levels. She was resistant to all traditional treatments, so the haematologist had suggested splenectomy. And this is because splenic sequestration of platelets was the most likely cause of her ITP, which is where the spleen's eating all of the healthy platelets. But there's a lot of risks involved with this surgery, and the patient was really hesitant, so they asked us to do a platelet study. ITP is a diagnosis of exclusion, so it's when the platelet count is less than 100, and that's 10 to the power of 9 per litre. And it's not very common. Incidence is up to a 6 in 100,000, and the most common symptom is bruising. You get that little petechiae all over. You can get nosebleeds, fatigue. Hemorrhage is less common. And steroids are the most common treatment. Usually be started on prednisolone. You can use others or rituximab, and splenectomy if none of those are working. Patients who aren't a consideration for splenectomy can have platelet stimulating agents. Diagnosing ITP can be really difficult. Serological testing is not that good. Bone marrow biopsies are really invasive. And treating it is hard as well. Steroids often don't work, so splenectomy is commonly considered for these patients. So back to our patient. She's a 37-year-old woman with a history of recurrent miscarriage and factor V. Presented to her GP with bruising, and when they discovered the low platelets, they admitted her to hospital and started her on prednisolone. The platelets did initially jump up, but by 21 days they had gone right back down to 29. Increasing their prednisolone dose had the same effect, and rituximab also didn't work. Splenectomy can be really useful for ITP if splenic sequestration of platelets is the cause. Works about 50 to 70% of the time. But there can be complications. Infection is always a risk, and these patients are a huge bleeding risk during and after surgery. And how do you know if it's going to work? Ultimately, you don't. So that's where platelet scintigraphy comes into it. There are studies from the 80s and onwards. You can use indiamoxine or Indian tropolone. And bear with me when I say these are some of the better images I found online. There was not a ton. So these two here are from a pediatric study. The bottom left is 1 hour post-injection of platelets, and it's a little bit hard to see, but the spleen is more intense than the liver. And given that at 1 hour post-injection there is no vascular activity, this is a positive study for splenic sequestration of platelets. The image on the right is taken at 24 hours post-injection in a different patient. And seeing as there is so much vascular activity still remaining at 24 hours, this is considered a normal study. This is from another study. The top two are the first patient. At 2 hours post-injection, the top left image, the spleen and the liver look very similar, almost looks normal. But by 24 hours post-injection, in the top right image, the liver is the most dominant organ, which is actually another variation of hepatic sequestration of platelets. Bottom left is another patient. At 2 hours post-injection, the spleen is more intense than the liver, and bottom right, by 24 hours, the spleen is the most dominant organ, and this is positive for splenic sequestration of platelets. So for our protocol, I felt comfortable using autologous platelets. Our patient had a platelet count of 40, and I had seen research online using as low as 30 successfully. And the labeling process is very similar to white cell labeling. We used indiamoxine and did 10-minute statics every day for 4 days. Here's just a timeline of what we did. We took blood samples, took 5 on the first day and then 1 each subsequent day, and imaging just 1 each day for the 4 days. The blood samples used to calculate platelet survival time. And here are the results. So you can see that by 2 hours post-injection, the spleen is the most dominant organ, and there is some vascular activity, but as time passes, this dissipates. And by 72 hours, the spleen is markedly more intense than the liver, and there's almost no vascular activity. So this was a positive study for splenic sequestration of platelets. We drew some ROIs to have a look at the vascular activity and the spleen to liver ratio, and it confirmed what we were seeing visually, that it was a positive study. The spleen to liver ratio is quite high, and there's minimal vascular activity at 4 days. Here's just a summary of the results. So the spleen to liver ratio at 72 hours was 4.3. and anything over 2 is considered positive. And we also calculated the mean platelet survival. Roughly 200 hours is normal, and this patient's platelet survival was 31 hours. So very reduced and in keeping what we were seeing visually. Here's just a graph of the bloods. So this patient did go on to have a splenectomy about 2 to 3 weeks later, and it was successful. The platelet count jumped right up initially, and even at a month post-surgery, they were still doing great and having a complete response. So this is a very successful case. Here is a graph I found from one of the biggest studies I found online. 70 patients looked at over 20 years. All of these patients had platelet scintigraphy and went on to undergo splenectomy, and this is a graph of response following surgery. So the solid line is patients who had a positive study. They had a 93% response at 20 years, whereas the dotted line is patients who did not have a positive platelet scintigraphy, and they had only 68% ongoing response at 20 years. So I think it's a really good summary that platelet scintigraphy is a good indicator of whether splenectomy will be useful in the long term. So overall, I'm really glad to be a part of this patient's management. The study accurately predicted that splenectomy was the best route for this patient, allowed the patient and the doctor to be a lot more comfortable going forward with splenectomy, and also the platelet survival time being so reduced gave a bit more insight into the severity of her ITP. I think we see a lot of cases these days with these brand new isotopes and quantitative SPECT data that are really incredible, but it was really great to be a part of an interesting case that just used old-fashioned, static-only nuclear medicine, and it was a really great contributor for this patient's management. Thank you.